Hello and welcome to our live stream event as we discuss what parents should know about eating disorders. My name is Kara Gavin. I'm with the Michigan Medicine Department of Communication, and our panel today includes three experts from our Comprehensive Eating Disorders Program who will discuss a group of conditions that have been on the rise in young people for many years, and especially the last few years. While we've titled this session What Parents Should Know, we hope the information shared today will be useful to grandparents, other family members, teachers, coaches, and more. And a warning, we may discuss some pretty distressing topics, including suicide. So if you or someone you know needs immediate help for an eating disorder or any mental health crisis, the National 988 Lifeline is the best place to start. You can call or text 988 from any phone or visit 988lifeline.org to connect via web chat. So to begin, I want to turn things over to our three experts for quick introductions, starting with you, Dr. Bravender.
Thank you, Kara. I'm Dr. Terrill Bravender. I am the Rosen Professor of Adolescent Medicine and Professor of Pediatrics and Psychiatry here at University of Michigan Mount Children's Hospital, and also serve as Executive Director of the Comprehensive Eating Disorders Program.
Thank you. Dr. Cwynar?
Hi, I'm Dr. Christina Cwynar, and I am a doctorate prepared nurse practitioner, and I'm dual certified as a pediatric nurse practitioner and a psychiatric mental health nurse practitioner, and I work on our consult liaison psychiatry service.
Great. And Dr. Prohaska?
Hi, I'm Dr. Natalie Prohaska. I'm a child and adolescent psychiatrist and the medical director for the Comprehensive Eating Disorders Program at Mott Hospital.
Thanks all of you for joining us. So before we start, for our audience, a few housekeeping items. If you're watching live, you can submit questions at any time for our panel to potentially answer during the Q&A portion. And questions can be submitted by commenting on the video on whatever platform you're watching live on. But please note that that means your name or your profile name will be visible to others who are participating. So if you prefer a more anonymous option, you can send a private message to us through the social channel that you're viewing this on. And if you can't stay for the whole chat, or you want to share a recording with a friend after the fact, the entire video will be available on our Michigan Medicine YouTube channel. So we'll get started with some questions, and hope our audience will start to send in some of their own as well. So let's start with the basics. What are the hallmarks of an eating disorder, and what specific diagnoses are included under that umbrella term of eating disorders? And Dr. Cwynar, do you want to tackle this one?
Yeah, so I think these are two different questions. So maybe the easier question to answer is the one about the diagnoses. So the term eating disorders is very general and very broad. And then there are many different diagnoses and more specific that fall under that umbrella term. So there's things like anorexia nervosa, bulimia nervosa, binge eating disorder, avoidant restrictive food intake disorder, otherwise specified feeding and eating disorder, pica, rumination disorder. And then there's other things and terms that we use that describe things that affect our body related to our relationship with food, such as orthorexia or compulsive exercise, diabulimia, that aren't formal diagnoses, but do contribute to that relationship and have poor consequences to our health. And then when thinking about people who experience eating disorder and what those symptoms look like, many people think about the refusal to eat or skipping meals, but diagnoses are much more broad and range from emotional and behavioral to physical. So on the emotional and behavioral side of things, there's things such as food rituals or preoccupations with weight or food or calories. There's things like withdrawing socially, body checking, mood swings, just to name a few. There's a ton of different things that you can observe. And on the physical side of things, there's changes in weight, stomach cramping, constipation, irregular menses, difficulties concentrating, feeling cold, syncope or passing out, muscle weakness, poor wound healing, dental problems, and there's many more. So just noticing different symptoms may altogether lead to a broader picture of an eating disorder. So families or loved ones, teachers may not specifically see somebody skipping meals or restricting food, because eating disorders are very sneaky and hide those types of things. They may put on a good front, and you may pick up on some of these other symptoms first.
Thank you so much. That was a great summary to start with. Now, we're doing this live stream during May, which is Mental Health Month. And Dr. Bravender, I wanted to ask about, are eating disorders considered mental illnesses? And what do we know about what makes someone more likely to develop an eating disorder?
So that's a great question. And the short answer is yes, eating disorders are mental illnesses. The diagnoses with some of the criteria that Christina mentioned come from the DSM, which is Diagnostic and Statistical Manual for psychiatric and mental health conditions. But the thing about eating disorders is, while eating disorders are serious mental illnesses, that have physical health complications, they are also serious physical health conditions that also have mental health complications. The best illustration of this, I think, is in individuals with anorexia nervosa, which is a condition that's really, the hallmark of it is severe or relative malnutrition. And we know that the compulsions that Dr. Cwynar mentioned drive a lot of the behaviors. And what we have found is that the weight loss itself and the malnutrition itself makes those compulsions worse. So the mental illness drives the malnutrition, and the malnutrition itself drives the mental health component of it. So what that really emphasizes to me is the need for a multidisciplinary, interdisciplinary team that can address all aspects of the illness, from the psychiatric components to perhaps the background psychological drivers to certainly the physical health components of it. And treating only one is not going to be helpful for treating the patient, and it really takes a more holistic approach. And your other question was, what is something that makes patients more likely to develop an eating disorder? And I would say, first of all, we live in an eating disorderogenic environment, if that's a word, where there's a lot of emphasis on how people look, and an idea, not just in the United States, but particularly in the United States and in Western worlds, that we can turn ourselves into whatever we want to be, and including weight. And there are messages about weight that are unattainable and should not be attainable for many people. Now, that doesn't mean everybody is going to develop an eating disorder who's exposed to those messages. And we know that individuals with high levels of perfectionism are at risk for developing anorexia nervosa. Other individuals who have high self-worth determined by how they look, with more, lower levels of perfectionism, but more kind of emotionally reactive personality types, may be at risk for other eating disorders such as bulimia nervosa. And I think that our colleague, Dr. Cynthia Bulick, who's at University of North Carolina, Chapel Hill, says it best when she says that society loads the gun, or genetics loads the gun and society pulls the trigger. So we know that there's a high genetic component to this, probably involved with the perfectionism and the emotional reactivity of the patient.
Thank you so much. So, Dr. Prohaska, I wanted to ask, do people with eating disorders often have other mental health conditions at the same time?
Yeah, I think that when I'm assessing somebody who has an eating disorder, it really is the rule, not the exception, that there is a comorbidity. It sort of varies based on what their eating disorder diagnosis is, but anywhere between like 50 and 90% of patients who have eating disorders are going to have some sort of comorbidity, whether that's anxiety, depression, sorry, or other diagnoses such as like suicidality and things like that. And so whenever I'm assessing a patient with an eating disorder, you do want to check in on safety concerns. So checking in on self-harm as well as suicidal thoughts, plan, intent. We know that asking those questions does not cause people to attempt suicide, that really you are assessing safety, reducing risk, access to lethal items. All of that is incredibly important. I think later we're going to talk about sort of the mortality rate with eating disorders, and 50% of folks who die from an eating disorder die from suicide. So really assessing the whole person and the comorbidity is very important, and certainly also affects what we're doing with treatment in the future.
Thank you. So we've definitely heard that from some recent studies and data from the Centers for Disease Control that there's been a sharp rise in the number of young people seeking care for eating disorders in recent years. And I believe we have some graphs that are going to show us some of this rise both nationally and right here at Michigan Medicine. So we're going to get those graphs pulled up, and I'll ask Dr. Bravender to talk us through those graphs, because I think it's important, in this climate where we are in the pandemic has been going on for 3 years now. Maybe it's not as much of an emergency from the COVID standpoint, but there have been changes, in the rates of people seeking care. Do we have those graphs up? I think we're getting those up. So Dr. Bravender, do you want to start as we get those graphs up and tell us what we're seeing? Oh, and
Sure.
The graphs are up. I just can't see them. So Dr.
Okay.
The first graph is the national graph. So if you can describe for us what.
Yeah. So these are data from a multi-center program that we participate in with, I think, 17 different adolescent medicine groups in eating disorder programs across the country. Our third-year fellow, Dr. Jessica Jerry, was one of the authors on this study. And this is really looking at outpatient appointments. So people who are coming in looking for treatment for eating disorders in the clinic setting. And you can see from the graph that it starts in January 2018, that there was a slow rise in the number of adolescents and young adults seeking treatment for eating disorders. Now, whether this is an increase in rates of eating disorders in the population or just more people looking for treatment, we're not sure, but clearly more people were slowly looking. And then the blue line is COVID-19 restrictions. That's when the stay-at-home orders went in, and there was obviously a sharp fall off because clinics were closed, people weren't coming to seek treatment. And then what was surprising is over the next few months, we saw a dramatic increase, and there all the way through early 2021, a really rapid rise in the demand for treatment services that is probably a true reflection of increased rates of eating disorders. And these are parents calling in. We saw many parents calling in desperate to get treatment for their children. Now, these are the outpatient appointments, and if you can move on to the next slide that we have.
Okay, I believe we are.
Okay, now the next slide is these are data from here at Mott Children's Hospital in Ann Arbor. And our colleague, Dr. Alana Otto from our division, was a lead author, but I believe Dr. Prohaska and I are also on this. But these are patients admitted to the hospital. So this is the tip of the iceberg of adolescents who are really the sickest with their eating disorders. So teens and young adults who have serious medical complications, meaning that they need to be admitted to the medical unit for medical management and really medical safety net rescue because of their severe malnutrition and severe physical health complications. And again, as you can see, from the blue line, we had a very slow increase over time. The graph starts in March of 2017. The red dotted line there is when the COVID pandemic precautions started. There was a drop off again, probably because people were sheltering at home and not coming into appointments, and then a rapid rise in the number of admissions for the most severe physical health complications of eating disorders. We have not seen a falling off of the number of patients admitted to the hospital for this. It's no longer increasing as rapidly as it was, but we've reached a plateau here. And the graph goes through 2021. We're here in 2023, and we have not seen a decrease in the number of admissions yet.
Wow, that's really powerful, very powerful data. And thanks for sharing those. And it's great to have that available. So just to clarify the term comorbidity, Dr. Prohaska, you used, just want to clarify for those who might not be familiar with that term, that basically when someone has more than one condition at the same time, chronic conditions, and they can have the physical condition and a mental health condition at the same time, that's considered a comorbidity. Is that correct?
Yes, exactly. Thanks for correcting me on that. So we really want to make sure, yes, with any sort of primary diagnosis, most people have other things going on. And so we call that a comorbidity, meaning another type of illness that's coexisting with the primary illness. And so if somebody's coming in with an eating disorder, Dr. Bravender is going to be checking on them medically, making sure everything's going well. And then I'm going to be checking on them psychiatrically once they're in our program.
Great. So having seen these powerful graphs, Dr. Cwynar, I'm going to ask you to start by helping us understand what might be triggering this rise, especially in the last few years, and especially what role do you think social media, popular culture, advertising, the news play in eating disorders in this rise that we've seen?
Yeah, I think there are many factors that have contributed to this rise. And I think Dr. Bravender and Dr. Prohaska can also chime in on this question. But what happened with us all quarantining and, sheltering in place is a lot of children and adolescents they lost everything. They lost their social contacts, they lost their structure. And the only thing that they could control was their food, some of them, their exercise. So, and it got to a point for some of these individuals where it just got out of control. So that was one thing that we really saw. Another thing was their uptick and use of social media. So then they were ingesting more of this content or diving down deeper holes into content that wasn't so protective. Maybe it was a little bit more dangerous and encouraging some not so healthy behaviors around food or exercise or other things that drove some of these behaviors. And then they got to a point where they were out of control. So with eating disorders, they may start out as a healthy thing. They may seem like a good thing, like I'm going to eat less junk food, and then it kind of spirals out of control at a certain point. And we heard that story over and over again. And for some people, it was food insecurity. And them all of a sudden, they don't have school meals, they don't have breakfast, and they don't have lunch. So now they're restricting because they don't know where their next meal is. And then it just got out of control. It was a lot of different factors that kind of all compounded at the same time. Some individuals were now exposed to even more stress at home. Maybe school was an escape from abusive situations. And now those were the situations that they had to deal with day in and day out. And like I was referencing before, this is what they could control. So there is a lot of different factors, and Dr. Prohaska and Dr. Bravender might have some additional thoughts on that too.
Yeah, I mean, I think it's a really interesting question. I don't think we fully have an answer to what has happened, but certainly I think multifactorial. I think many kids at some point in their adolescence may have had thoughts about their body. And then you sort of place them in a scenario where, yes, there's nothing else going on. And so they're in this vacuum. And there was actually a lot of talk at that time about like the COVID-15 and things that was going to happen, or challenges for different exercise. So people were filling their time with all of these different sort of media and things like that. And so maybe this was a kid who had thoughts previously but never acted on them. And now they have this time and this sort of vacuum. And I think, like Dr. Cwynar said, things can start small, and depending on their risk factors, sort of spiral from there. And so we know that if it was just social media, then everybody would have an eating disorder. But we know that there are risk factors that sort of predispose somebody to experience those same sort of triggers in different ways. So the same, two children can read the same article or hear different things and have a very different internal reaction to that. So I definitely think that the stories that Dr. Cwynar was talking about, as well as what I was sort of talking to, are some of the stories we're hearing. And I think there's going to be a lot of ongoing talk about what sort of happened during the sort of isolation of COVID.
And we know that children and adolescents thrive on predictability as a way of feeling safe. And we all know that nothing seemed predictable in 2020. It wasn't. And that lack of feeling safe meant it felt like the world was a dangerous place. And like Dr. Cwynar said, there are only a certain number of things that one could control. And maybe food was it for some of the youth. I think also I've heard, again, this is anecdotal, so take it as it is, but I think we've all had our patients tell us, well, I was in Zoom class all day, so all I did was stare at myself. And we know research data shows that no matter how hard you try not to, if anybody is on a Zoom call, you look at yourself all the time. And it's hard enough for adults to do that, let alone if you're a developing 13 or 14-year-old, to not have some feelings about that and not try to control how you look. And the other thing is the loss of extracurricular activities such as sports. I think many of our patients overcorrected because they were worried they were going to get out of shape from not being able to participate in cross country or basketball or whatever they were playing, and decided to either alter their eating because of that or put themselves on what ended up being a harmful exercise regimen.
Wow, a lot to digest. Thank you all for helping us try and pull apart what might be happening. And we, of course, are still in a pandemic and we don't know all the things that are going to happen over time. But something that I've heard is that there is a lot of stereotypes and preconceptions out there about people with eating disorders. And, what are some of the most common, or what's the reality versus the myth? And Dr. Prohaska, if you want to start with taking this one.
Yeah, I think there's obviously a lot of myths. I think one that comes to mind, and something that sometimes parents will bring to us, is that an eating disorder is a choice, that the child has chosen this, and if they would just eat, everything would be fine. Unfortunately, we know that's not true. We know that if it was something that they could fix, they would do it. And we really know that these are disorders in a biopsychosocial manner that have multiple triggers, like we've talked about, and there is no choice here. I think the other thing that comes up frequently for parents that they've heard is that parents somehow caused an eating disorder. We know that this is very much not the case. And when we later talk about some of the treatments, we can talk about how vital parents are to actually curing their child's illness. So we really view parents as a resource and vital, not to be blamed for what has occurred. And another thing that's really important, and Dr. Bravender and I have done some talks about this, is what does an eating disorder look like? I think when you picture an eating disorder, you imagine a thin white woman. I think we know that eating disorders cross all barriers. So different races, ethnicities, we know that the prevalence is very similar amongst these. The other thing is thinking about men, thinking about transgender. All of those components are incredibly important, and we need to be monitoring for symptoms of an eating disorder, no matter what the person looks like, including what does their body look like. So recognizing that any body shape or size can have an eating disorder, and a very significant eating disorder. I think, unfortunately, there is this idea that weight loss is the sort of main indicator of severity. Certainly, we know malnutrition, and we need to treat that. And eating disorders can come up in anyone. And so when we are trying to, our sort of unconscious biases about who has an eating disorder could get in the way of who's getting referred to us. And we unfortunately see this. We know that the prevalence is the same, and yet the type of patient that is coming to us, very sort of skewed to white women. And so we want to make sure that we are saying everybody should be monitored for, and let's screen for this, that just looking at the patient alone is not enough. So those are some of the ones that come to my mind.
Thank you so much. And just a reminder for those who are viewing this live, you can enter a question on the platform that you're watching. And we have folks looking for those questions and passing them along to me for consideration. So thanks. So we have a person who asked a question through LinkedIn, what the main reasons behind eating disorders. And Dr. Bravender, you touched on this a little bit, that there are, genetic components and other aspects, but would any of you like to go further into what we know and what we don't know about what sets someone up for an eating disorder?
I'll expand a little bit, and then I'll let others chime in here too. I think I'd mentioned high levels of perfectionism are a significant risk factor for anorexia nervosa. And combined with that, and by perfectionism, I mean really exactly that, wanting everything to be perfect, believing that you can control all your outcomes. And that can be really helpful. People with high levels of perfectionism tend to get very good grades. You probably want your doctor to have high levels of perfectionism because you want them to pay attention to things. What raises the risk higher for anorexia nervosa is high perfectionism combined with a low self-evaluation. So a feeling that I have to do everything perfect, but the young person never thinks they're good enough and are always striving for more. So despite a 4.0 GPA, thinks it isn't good enough. Despite losing, some amount of weight, thinks it always has to be more and more and more, and can never achieve that perfectionistic ideal. Now, the etiology, we have parents ask us on a regular basis, like, what caused this? What is the deep down root cause of this eating disorder? And in children and adolescents, the reality is there may be nothing aside from these global exposures that everybody has. There may be a genetic component, there may be some exposures, there may be an internalization of certain messages. Something started it, and the reality is, for treatment, it doesn't matter. Because if you can treat the eating disorder, get back to a healthier place, a healthy weight, more regulated food intake, regulated other exercise behaviors, then whatever caused it in the past will be back in the past.
Thank you so much. So let's start talking about in the treatment and diagnosis world. Dr. Prohaska, you mentioned screening. So Dr. Cwynar, can you talk us through, what do we know about how long it sometimes someone can have an eating disorder before being diagnosed or getting into treatment, and why does that happen? And does earlier detection and treatment matter?
Yeah, so clinically, I've met people all over. So I've met people who, started experiencing eating disorder symptoms 3 months ago or years ago. So I really, when you had prompted us with this question, I went to the literature and said, where are we kind of on a a national, a global level, how well are we doing? So in 2021, so a very recent study, there was a systematic review. So that means that they looked at several different studies, and this looked at 14 studies from 7 different countries. So across the globe, how are we doing? And they found that the duration of eating disorders that go untreated is about 2.5 years. So a little while before we're getting people into treatment. And that was for anorexia. And then for other eating disorders, it's a little bit longer, about 6 years. So we're struggling a little bit getting people into treatment and diagnosed and all of that. But what we do know is that people who get treatment earlier do better prognostically. That there are high rates of relapse, especially in individuals with anorexia, even those who have gone through high levels of treatment, such as residential treatment. And those numbers range greatly in the studies, anywhere from 9% all the way up to 65%. And then approximately 60% of individuals who seek professional treatment do reach full recovery. So there is hope out there, and it's just seeking that help and keeping at it. But it's really that multidisciplinary team. And as I think it was Dr. Prohaska mentioned earlier, engaging the family and really using that as a resource and empowering family through this process.
Thank you so much.
So, hey, Kara, I just wanted to add one thing, because I think that's another myth that comes up, is that these patients cannot reach full recovery, that this is something they have to deal with for the rest of their lives. And we know that is not the case. And so we want to give people hope that, yes, the statistics are not great. And of course, we want to get people in and we want to get them good treatment. But your adolescent can fully recover from their eating disorder and move on and have a full life ahead of them. So we don't think about this as sort of like an addiction that will be there for the rest of their lives. People can have an episode of an eating disorder and reach full recovery. And that's why we push so hard in our clinic to really hit the ground running, get the treatment going, get the behaviors under control, because we know that that can lead to a better prognostic factor for full recovery.
Very important note. Thank you. Thanks for adding that in. So Dr. Bravender, at the start, you mentioned some of the warning signs or things that we can see in young people who have an eating disorder, but some of those might sounds like they go unnoticed or not attributed to an eating disorder. So just for our audience, again, talk through what kinds of things could parents or coaches or teachers be looking for?
So I think it's really important to be alert for eating disorders, but not kind of, I guess, overly confrontational, because there are a lot of teens will have kind of strange food habits on occasion, or they eat a bag of Doritos once in a while on their own, and some of that is totally developmentally normal. I think there are some warning signs to look for, and most importantly, I think, is for parents to kind of check their own messages too about what they're communicating. This gets more into the realm of prevention, but just not using food as a reward, and communicating more healthy messages about food, and not dividing food into like healthy or unhealthy types of food, and communicating that we should enjoy eating food, and we should enjoy eating a wide variety of food, and there's nothing inherently bad about any specific food. And then if I could choose one thing for families to do that's protective, that's eat dinner together as a family as often as possible. And that can be, that's supportive for so many different outcomes. We don't even have time to get into it. But one of the warning signs we've seen frequently are families who did eat dinner together as a family, and then suddenly one of their children says, "Oh, I'm too busy," or "I've got homework to do," or "I've got to stay at sports practice longer." And it's a way of avoiding that food interaction, and there may be some restrictive eating going on. Now, it may just be that the child really is particularly busy, but it'd be great to keep that the family value of family dinners present. I think other things, any attention to weight loss or any communicated kind of obsessiveness about weight, eating, and exercise, I think are really important to pay attention to. And for coaches, I think emphasizing that their students or their athletes who are on the team should not be doing independent workouts on their own that the coach doesn't determine for them. If you're on a cross-country team, you should run the amount that the coach tells you, and running more is not going to be helpful. And I think just keeping alert and aware on the part of the parents. And then for primary, and the other piece that parents can do is making sure that their adolescents have an annual check-in with their primary care provider who can really assess weight, general nutrition status, for girls, menstrual status, which is an important marker for nutrition, along with a history about their eating and weight perceptions.
Thank you so much. We've had a question from somebody watching this on YouTube. It sounds like perhaps they suspect something's going on with their child, or maybe have tried to get them to be seen for possible eating disorders. But so, what is it that that somebody can do to help convince their child basically to go seek help, or can you just say, we're going to have a checkup, but actually have told a provider ahead of time, I'm suspecting an eating disorder here? Not sure which of you would like to take that one.
Yeah, I can take that one. One of the difficult things with eating disorders is they are called, we refer to them as egosyntonic, meaning that the individual themselves does not necessarily want to get rid of the illness. And that is due to their distorted perception of themselves. And so for them, the idea of getting treatment for an eating disorder can be very terrifying. We are asking them to do their greatest fear, which is weight gain. And so for many adolescents, they're actually not very in favor of getting treatment. And so as a parent, it is really important that if you are concerned about their medical health, that you bring them into their primary care provider. I think definitely reaching out ahead of time, letting that provider know, or having some time separate with the provider and separate with the child. But I think it is important to recognize many people with an eating disorder are not in favor of treatment, in particular when we're looking at anorexia. And so if a parent has a concern, it's really important to bring your kid in. And of course, we want to respect their autonomy, but in those moments when the eating disorder is so big, the child is not able to think clearly and rationally. And so as the parent, we have to sort of step in and say, we need to get treatment. And so sometimes we can't wait for the adolescent to be on board.
And I'm gonna add a little bit to that. You mentioned the egosyntonic nature of the eating disorder, that it fits in with the adolescent's perception of themselves, and they see nothing wrong with it. That's in counter to what most illnesses are. Most illnesses are ego dystonic. So if you've got a broken leg, you don't want to have a broken leg. If you've got strep throat, you don't want to have strep throat. That's why you go to the doctor. But with an eating disorder, because they're often egosyntonic, especially at the beginning, the young person may not have any interest in it, and that's okay. We expect that, and that's why we really emphasize family-based treatment.
Great.
And I think it's also okay for the parent to say to the child, I'm worried about this, and using those I statements rather than saying, you've got a problem, we're going into the doctor. Not that a parent would say that, but you want to emphasize the I statements. I'm worried about you. Maybe I'm making too big of a deal about nothing, but let's get a consultation about this.
Right. We also had a question that came in. We talked a little bit ago and showed the graphs showing the rise during the early months and year of the first year of the pandemic. But that rise continued. And so someone's asking about, all that restriction is over. Masks are pretty much gone in many places. Kids are back in school and sports and clubs. Why would someone still have an eating disorder, or why would we be seeing new diagnoses? And I think Dr. Cwynar, you mentioned about how people often go for multiple years without being diagnosed. Do you think that's part of what's going on here, or what else could be happening?
I think there's many factors that could be happening. One of them is just what you said, people have gone years without being diagnosed. Another is people have struggled with being reintroduced to school. So some people really thrived with being home and doing school via Zoom or being homeschooled or whatever platform, and have now struggled with the reintegration, or now they're being bullied, or they're just at a new phase of life. So it hasn't all been completely related to the COVID-19 pandemic. There's other factors related to the development of an eating disorder. And so I think we still see those, and in general, the rise of mental health conditions that are comorbid with eating disorders that have contributed to the ongoing rise. But everybody's response to and their journey through an eating disorder is also different. So we often meet individuals who will tell us, it started out as this, and then it slowly increased to this. So their journey just may have been very different. So it may have taken them longer to get to a severe enough spot that somebody was able to say, you know what, we need help now. Where others, it was a very rapid drop to that spot. And that's why we saw them a lot sooner.
So let's talk about what happens when someone does get into treatment. And Dr. Prohaska, maybe can you talk us through what sorts of treatments have been shown to be effective? And is it true that food almost acts as a form of medicine in this case, as well as things like talk therapy and medication? So
yeah. So absolutely. We talk about it over and over and over again. Food is your medicine. I think our patients get exhausted by us saying that. But it is a constant that we can all go back to. As a multidisciplinary team, we say, this is really so important. And until we can get you the medicine that you need, everything stops. And so like Dr. Bravender said, we start with a psychological component and can go into physical, and then the physical worsens the psychological. And so really, we do have to treat that malnutrition, get the behaviors under control to really get the brain at a place where it can actually do sort of the talking work. So in general, we cannot talk somebody out of an eating disorder. A lot of times we really have to start with the behavioral components. And that's where, because of the egocentric nature of an eating disorder, a lot of times you have to involve somebody else to help the individual feed themselves. So when the person is really struggling, they don't see that there's a problem, and they feel like, if everyone just left me alone, I would be fine. And so as providers, as their parents, as their caregivers, as somebody who is in their lives, are saying, no, right now you are not at a good place, and we need to get you your medicine, which is food. So what does that sort of treatment look like? The most evidence-based treatment for adolescents with anorexia as well as bulimia, and there's growing evidence for ARFID, which is a type of eating disorder that is not body image related, but there's some sort of avoidance or restriction of food that's due to, sensory sensitivity or fear of choking or things like that. So there is evidence growing that FBT can be helpful in all of these sort of diagnoses. For adolescents. And really what it's saying is, at the moment that the patient is entering treatment, that child's brain is not able to feed them enough to get their brain and body nourished. And so it is now the responsibility of the parents to take over that role. And that's why we talk about family being so vital for the recovery of an adolescent, because they know their child best, right? They have been feeding them since they were born. And so they really are the best people to know what their child needs. And of course, we are there as experts to support them and to empower them. And they are really there for their adolescent. Now, that is incredibly a lot to ask of a parent, and that's why we have treatment teams to support them. But really, that family-based treatment, the other name for it is the Maudsley model. And so that type of treatment tends to be the most effective. When we looked at comparing FBT to individual therapy, FBT was twice as likely to get somebody weight restored and into recovery. So we know that in general, this is the most evidence-based treatment. We certainly know about CBT for eating disorders. There's also DBT and other modalities, but FBT is the primary.
So CBT and DBT are forms of talk therapy, is that correct?
Yes, exactly. Cognitive behavioral therapy, dialectical behavioral therapy, they're more individual based. So looking at cognitions, how can we challenge cognitions? How can we change the way we're managing distress? All of these things are kind of involved in those types of treatment. And also you mentioned medications. Medications are not always very effective either. So unfortunately, there really are no FDA approved medications for adolescents with any sort of eating disorder. There are a couple in adults, but none actually for anorexia. So a lot of times we're using medications more as an adjunct to keep somebody at the lowest level of care. So if they're really, really struggling, we can provide a medication just to kind of help decrease the distress so that they're able to get in the real medicine, which is their food. But in general, medication is sort of just an add-on. It's never going to be the only type of treatment.
Great, thank you. So let's talk about levels of care. And Dr. Cwynar, maybe talk us through, what are those levels? What are the more intensive forms of treatment if the family-based with support from mental and physical health professionals is not sufficient? What other options are available?
Yeah, so let me break it down this way. So there's about 5 different levels of care that we talk about. And I think the one you were referencing is our lowest level of care. And even at that level of care, it takes a robust team. So that is your outpatient level of care. And that team should include, the family. It should include the primary care doctor, an adolescent medicine specialist, a therapist who specializes in eating disorders, a dietitian that specializes in eating disorders, and potentially a psychiatrist, depending on the mental health comorbidities. And then when you're thinking about more intensive levels of care, the next step up from that is what we call intensive outpatient programs. Those are programs that run usually a couple days a week, 3 days. Some of them are half a days, a few hours a day, and they provide programming to support the eating disorders. There are a few in the state. Ours has one, but usually ours is a step down from our partial program. And Dr. Prohaska and Dr. Bravender work in that program, so they can provide a little bit more details about that. And ours is family-based as well. So very important, an emphasis on family-based. There's very few other programs in the state of Michigan that provide the family-based care for eating disorders specifically. So the next level up from that is the partial hospitalization programs, and those run 5 days a week, and they're like your school days. And what those look like is you have, your family support where they're learning how to help support the child, the adolescent with their eating disorder. The patient is, going through programming, going to therapy, meeting with their medical team, their psychiatrist, those types of things. They get school support through our program as well, because that's often a stress. They don't want to miss school, but we also need them healthy as well to thrive. So that is a very intensive program. So that's the next step up. And then the step above that is kind of two-pronged. So the first prong is your medical side. So this is where we medically admit a patient because they are medically compromised and they need medical stabilization. These are patients who are really struggling. They need medical attention. Here at the University of Michigan, we have a discipline approach, and they get to see, they get to see me, they get to see psychiatry, they get to see adolescent medicine, and we work together to help stabilize. We do a lot of psychoeducation with the family. We work on next steps, whether that's stepping down to the partial hospitalization program or looking at next steps in treatment. And kind of partnered with that is we can think about a inpatient psychiatric admission. And what that is for an individual who isn't medically compromised, but for whatever reason, their eating disordered behaviors are not able to be managed on an outpatient setting. So they're interfering to such a degree that family can't manage them at home, because even if they're enrolled in a partial program, they go home in the evening and family has to manage those, all evening, overnight, and over the weekend. So maybe this patient is running away or exercising all night or whatever it may be, and they need that additional support. And that team can help with those types of interventions. And then the last level is residential. And that's where somebody goes and they live for a little while and they work really intensively on this disease process. In thinking about adolescents and children, there is no residential programs in the state of Michigan. There is one adult program in the state of Michigan. So it is a big decision to make with your medical team and as a family to make that step, but sometimes a very successful decision, and one that people often step back down to our partial program after.
Thank you so much for that summary. And there are some online programs, I understand too, sort of that are available, but not for all these levels, obviously. Let's switch over to the sort of the physical effects, sort of short-term and maybe long-term, that having an eating disorder can have on a young person's body. And what are these and how do you treat those, Dr. Bravender?
Sure. So thanks for that question. And Dr. Cwynar mentioned that one of the components of the treatment levels includes potential for medical hospitalization. And in our slide about the increase, that was pretty dramatic. We showed that earlier. There are a variety of health complications that can occur, usually around malnutrition, but can also occur with severe purging, so self-induced vomiting. There are a number of metabolic derangements, and we have specific criteria for who needs to be in the medical hospital. These usually involve the degree of malnutrition as measured by the percent of weight lost and the rapidity of that weight loss, or the absolute weight below a certain level, usually below 70 or 75% of where we expect their body weight should be. There are the numerous complications with malnutrition are related to really metabolic slowing. So as I explain to our patients frequently, it's real that there's an issue of energy imbalance. So calories are nothing but a measure of stored energy. And I don't know if our people want to know the chemistry of calories, but we'll go through the chemistry and the calculation of calories sometimes with our scientifically interested patients. But a calorie is nothing but a unit of energy. And if you're not taking in enough energy, your body will do everything possible to conserve energy. So that means slowing everything down. So just like you might conserve energy in your car or in the furnace in your house, patients will become cold, conserving energy. Everything slows down. Their intestinal system slows down, so they may be severely constipated. Their stomach doesn't work. Food doesn't move through well. Their heart slows down. You see really significantly slow heart rates. Their blood pressure drops, and even their brain function slows. And they may have what we call neurocognitive slowing, where you can actually tell people are just not processing information as well. All of these are signs of medical problems that might need inpatient management. Other problems with, as I mentioned, self-induced vomiting may cause severe blood chemistry problems that can result in heart arrhythmias, muscle cramping, and in the worst case scenario, even death. Those are the short-term acute consequences. If you get treatment and come in the hospital, everything will get better. And I'm very clear with our patients too. They get very worried about their heart health, very worried about their intestinal health. If you're able to get back to a healthy weight, all of that gets better. And as a teenager, when you get treated, there's not going to be lasting damage done. So the earlier you get treated, the better you're going to be. Now, if things aren't treated and the eating disorder persists, there are some long-term complications. And there are mental health complications. There are also physical health complications. For teenagers, an untreated eating disorder over the course of years can, especially if you're underweight, it can result in lost height growth. So if you are not taking in enough calories to grow, you may not gain those inches back from your teenage years. Other issues, particularly we can see it in young women, is having to do with lost menstrual function, and that has to do with hormonal suppression that occurs with poor nutrition. That happens in boys too. They also have their hormones suppressed, even though it's not as obvious in boys. It happens, and in both girls and boys, that malnutrition can result in poor bone health, decreased bone mineral density, and risk of osteoporosis later in life, with ongoing risk of bone fractures later in life.
And you mentioned dental as well earlier.
Yeah, and people with both bulimia, so if you have self-induced vomiting, but also if you're malnourished, you have increased risk of having multiple cavities. So I think if all of a sudden, your child who's had great dental health and no problems, and the dentist says, hey, he's got 6 cavities right now, what's going on? I would be concerned about eating behaviors.
That's an interesting warning sign I didn't think of. So I want to get to some of our questions from the audience, but I did want to touch on a point that we referenced briefly at the start, which is this idea of anorexia especially is sometimes called one of the deadliest mental health conditions. And is this true? And Dr. Cwynar, I think you might have some data on this for us.
Yeah, so unfortunately is true to a few levels. So first, individuals with eating disorders are at risk for a variety of medical complications, like Dr. Bravender was just talking about, including premature death related to this, and up to 20% of individuals with chronic anorexia die as a result of their illness. Second, individuals with anorexia nervosa are 31 times more likely to complete suicide compared to the general population. And for individuals with bulimia, they're 7.5 times more likely than the general population to complete suicide.
And just a reminder for everyone watching who knows someone who might be thinking of or acting on suicidal impulses, 988 is that number to call or text, or the website 988lifeline.org. So just want to mention that right after mentioning that very disturbing set of data. Thank you for getting that for us. We had a question specifically about binge eating, especially in teens who have anxiety. And so we've talked a lot about anorexia, but maybe binge eating disorder is considered a separate disorder, but binging can also occur in other conditions. So I'm not sure who'd like to address that, and especially that intersection with anxiety disorders.
Yeah, I can take that. So we do know that, yes, there is a genetic component to all eating disorders, and we know that through different like twin studies and things like that to know what is sort of the genetic component. But it is pretty high in a variety of eating disorders. And I think that perfectionism that Dr. Bravender was talking about, I think tends to go hand in hand with anxiety. Anxiety for people who who experience anxiety, they feel very out of control, right? Anxiety can be a very painful, sort of scary experience for the individual. And so sometimes they can be managing that anxiety via different things. So that could be via binging to sort of provide some relief and some, a distraction from the anxiety. It could be purging after. A lot of times we see compensation that occurs after binge eating, which is where sort of bulimia comes in. And then with anorexia, those people have a lot of rules, right? So they are following sort of a guideline that they think is right. And so all of these components, that sort of psychological component of eating disorders, anxiety very much plays a role. I think we definitely also see a lot of mood issues. So the mood dysregulation, as well as just sort of low mood and poor self-esteem, all of these things are sort of intertwined. And I say sometimes that eating disorders and anxiety are like best friends. They tend to go together. And so we know that those things kind of play off each other a lot.
Thank you so much. And I think we're running out of time to take additional questions. Thank you for everyone who's submitted questions online. I think we've gotten to many of them. But I also want to just really quickly, if I'm hearing from all of you some very serious information, but also a glimmer of hope that if people do get into treatment, and if people take action to help someone get into treatment because they may not want that treatment themselves, that there is hope. So any concluding brief thoughts from any of you?
Yeah, I think that we do know that there are evidence-based treatments that can really give a family and a child a really good fighting chance at getting full recovery. And so don't be afraid to reach out for support. We recognize that the mental health sort of world is sort of somewhat strained right now, resources and things like that, but there are also online resources. I think we're going to provide some options, but there are some even family-based type websites, including where you can get 30 days of free emails, where it can provide a lot of information. And so do your research, find some resources. You really can help your child.
Great, Dr. Bravender, Dr. Cwynar.
I think kids can get better from eating disorders. Dr. Prohaska said that. And the eating disorder is something that will be eventually put in the past. And I have many patients who are able to look back and talk about, back when I was sick, I thought about this, and now I'm not. So I want to keep that sense of hope, despite all the complications that we can see.
Thank you.
I think the last thing I would have to add is just keep asking for the help. We see a lot of people who come from very far away looking for help, and we're always here. So even if it's, your primary care doctor reaching out to our teams to ask for help, there's help out there. So just keep asking. And if you're worried, there's the right help out there.
Thank you all for being part of this. I will close with some brief mentions of some of those resources. Again, the 988 Lifeline for calling, texting, or web chat for sort of immediate, critical, or even crisis types of situations. The National Alliance for Eating Disorders has a locator site for treatment options at findedhelp.com. And on that website, they also have a phone number you can call to get connected with trained folks. And then that website that offers the 30 days of emails is from the organization known as Feast. And their website is feast-ed.org. Again, feast-ed.org. So any of those resources I think are great to reach out to. We really appreciate everyone who tuned in, our three experts. And again, this recording will be available for everyone to share and watch again. We really appreciate you. And thanks again for joining us.